Hey, good morning, guys. We're back to do another positioning video. Today we're talking about the wrist. Couple things I wanted to talk about real quick. These are going to be posted to the Sterling Hub under the radiology group. So make sure you join the radiology group so you have access to these. These are going to be very helpful going forward, learning how to do x-ray. You can go and look at those and figure out how to do the x-ray that you're wanting to do. So they're actually very helpful. Also, I'm going to be posting these to YouTube under the page, the Wyoming X-ray guy. That's me. I had to come up with something, and that's what I come up with. Pretty original, right? Anyway, just so you know, you can go there and you can subscribe to that page, and you can see these positioning videos as well. So let's get started. So wrist series. We do a lot of wrist series here in our clinics. Seems to be one of those bones that people injure quite often. So let's go through this real quick. The projections for a wrist series are a PA, oblique, lateral, and if they have an injury to the scaphoid or navicular bone, we're going to do a navicular ulnar deviation view, and I'll show you how to do that. SID is 40 inches. Central ray is going to be right at the mid-carpal. Collimation, make sure you are including both lateral and medial wrists. We want to include at least half of the metacarpal and a quarter of the radial ulnar distal ends. So technique 50 to 60 kVp, 3 to 5 mass. We want good contrast, so we're going to use a nice low kVp. It doesn't take much to get through a wrist. Tips for a wrist, make sure you curl your fingers under when you're doing the PA. And the reasoning for that is it places the wrist bones closer to the image receptor, which is what we're trying to accomplish, right? We're going to have some minor superimposition of the metacarpal bases. That's normal. On the PA view, the articulation between the radius and ulna should be open slightly, okay? So we need to see a space between the distal radius and ulna, okay? And okay, there's that for your reading enjoyment later. So let's get started. We've got Kate with us again today, and Mikkel is our lovely videographer. So let's get started. We're going to do Kate's left wrist. Okay, we're going to move Kate so that her arm is straight onto the IR. You can also sit with the patient facing you, and they can put their elbow in a 90-degree angle. But this is the way I prefer to do it. Seems to be a little bit easier on the patient. Always keep patient comfort in mind. You can see that her arm is pointing down a little bit. So we're actually going to bring the IR up a little bit just to make that a little more comfortable for her. Okay. The elbow and the wrist are on the same plane. Very important. Okay. So PA wrist, we're going through the posterior and we're exiting the anterior. Okay, our central ray is right at the mid-carpal region, right here, okay? Note that Kate has her fingers curled in, and we can actually bring that up a little bit, and that's gonna put the wrist closer to the image receptor, okay? That's the reason we do that. If those fingers are out there straight, you can see that there's a space between the image receptor and Kate's wrist. So go ahead and bring your fingers in, and bring that up ever so slightly. You can see that her wrist is against the image receptor now, okay? That's the reason we do that. So PA, we're just gonna collimate tightly. We wanna see light on both sides of the wrist. We're gonna mark this with a left marker because it is her left wrist. Make sure we're putting that marker on the lateral side inside the light so we can see it. Okay, so we've included distal radius and ulna. We can actually collimate that a little bit tighter. We need to get at least half of the metacarpal bones, right? So this is perfectly collimated. So we're gonna place our lead shield on Kate, and we're gonna shoot this between 50 and 60 kVp and a 3 and 5 mass, okay? There's your PA. So Now we're going to move on to an oblique, which is my hands are cold, I'm sorry.
Very cold.
45-degree angle. We're just going to lift Kate's wrist up laterally. Okay, so it's an external oblique. Okay, just like that. Same central ray. We're going right into the carpal bones right here, mid-carpal bones. And we're going to shoot that same KVP mass combination. Okay, lateral. Remember, we're going straight up and down. Okay, little tip for you. If you put your finger right here on the radial styloid right here, and your thumb on the anterior side of the ulna, you can tell if that is skewed one way or the other. Okay, and you can do it with either hand, finger here, thumb there, and you can tell that those are superimposed over each other. Okay, straight up and down. We want those bones to be lined up straight on each other. Okay, same central ray, mid-carpal area. Make sure that's good and lateral. Hand doesn't matter. They can stick their fingers out. They can put their thumb in the air. It doesn't matter. Okay, just as long as that wrist is in a lateral position. Okay, so ulnar styloid. Very good. We're going to go back into a PA projection here. Okay, so we're looking at the scaphoid, and if you feel right here, right at the base of the thumb, this is called the anatomical snuff box. Okay, it's a soft tissue area right there, and that's kind of where we're looking. Okay, is what we're trying to do with this is we're trying to single out the scaphoid, right? So what we're going to do is we're going to ulnar deviate, which we're deviating towards the ulnar side. Okay, and we're going to loosen this bad boy up because there's actually a 15-degree angle. Okay, we're going to go 15 degrees. We're going to put this at 15 degrees so it's parallel with the floor, right? Close enough, guys. Okay, so we've got 15 degrees towards Kate, or towards Kate's elbow. Our central ray is right over the scaphoid, and we already have a full series of the wrists, so we can go ahead and collimate as tight as we can on that scaphoid bone. And the reason for the angulation of the tube is to single and foreshorten the scaphoid. Okay, we want to be able to see all four sides of that scaphoid bone. And this is important. Scaphoid injuries are very common, and sometimes they're occluded when you don't do this view. So it's important that you know how to do this view. Just remember 15 degrees towards the patient, and you're going to collimate to the scaphoid bone. Okay, we're going to center right over the scaphoid, or navicular, whatever you want to call it. It's the same bone. So we're going to mark that bad boy, and we're going to shoot that same KVP mass. Okay. All right. That is a wrist series, guys. Any questions, please reach out. I do have a couple questions for you, though. Who is my videographer today? I know I've mentioned her name a couple times, and she is a relation of mine. She's really cool. And let's see, what else can we ask? What view is very important to see the scaphoid or navicular bone? Okay, when you watch this video on Sterling Hub under the radiology group, just jot down your answers. That way we know that you've seen it. And go on YouTube and subscribe to the Wyoming X-Ray Guide channel. That way you can go there whenever you want to, and you can watch these videos and refresh your mind on how to do some of these things. We are going to be running through all the images that we do here at Sterling Urgent Care, which is a lot. So stay tuned. They're going to come a little more frequently now that the holidays are over. But we appreciate you tuning in, and we'll see you next time. Bye.